who's an associate professor of medicine, consultant gastroenterology and advanced endoscopy at King Khalid University Hospital, Riyadh. He's also the president of Saudi Gastroenterology Association. He's going to talk about the Saudi Gastroenterology Association position statements of colon cancer in Saudi Arabia. In other words, should we adopt colon cancer screening in Saudi Arabia?
It's not actually a talk, it's questions for the audience. So I'm not going to give any talk. So kindly, Dr. Nasser Faisal, if you can be on the panel, and Dr. Omar. Okay, so it's mainly questions. First of all, I have to really thank our speaker. I think this is one of the best really lectures, starting with Omar and Faisal talk about the colon cancer in Saudi Arabia, and Dr. Nasser really tackle very, very important really questions and challenges about CRC, colorectal cancer screening in Saudi Arabia. So now I'll open the panel for everybody indeed, and then we'll probably target some questions to our panel here about questions and answer about colon cancer. Can we have the first slide, please? So I'll start with this statement. Do you think colon cancer screening can reduce CRC-related mortality? This is from, so if you totally agree, 1, 2, as you can see, so can you use your voting system, please? Are we okay now? Can we see the result? Okay, so we start usually with very basic questions. So at least 1 totally agree and 16% partially agree. I would like to know who's this 2%. Okay, so can we go to, so I think this is a very important start to, at least we know that colorectal cancer screening is a very important, irrespective of wherever it is, but that's a very, I think, important step to start with. So next question. Colon cancer is an important health problem at Saudi Arabia. This is a statement. What do you think about this? Totally agree, 2 partially agree, 3 partially disagree, and 4 totally disagree. Can you vote? أنت حماد ال 2% ولا؟ Okay, can we see the result, please? Okay, so it's again almost the same thing. So at least we know that colon cancer screening is very important, and we know from Dr. Faisal talk that it's a very important, also from Dr. Nasser, that it's a very important problem when you say it's a younger age. It's probably 55-year age, is the male or female according to Nasser and Faisal, and we think it's a very important thing. Dr. Faisal asked a very important questions. You mentioned these kind of national disasters, road traffic accidents. It's very important. So why do we have to care about this? I say, in my opinion, I think we already care about this already. We're treating colon cancer metastatic patients. I've been at one time in our PNT committee in the hospital. We're discussing Avastin, that's about 6 or 7 years ago, discussing Avastin, and just to see how much it costs, it's unbelievable. So indeed, if we say no, okay, we will not treat any colon cancer anymore, then I might agree with this, and I said, okay, but you're already spending a lot of money to treat, unfortunately, the advanced stage. So in my opinion, it's not an argument when some people say, oh, let's start with this. You're already spending a lot of money on metastatic or advanced colon cancer. So to spend this money in prevention, I think for anybody it makes a lot of sense. Can we have the next slide? It's important to screen for colorectal cancer at Saudi Arabia. So I'm expecting here things might change here. So do you agree with this totally, partially, or disagree? Vote, please. Okay, can we have the voting system? Okay, so it's even better than that. So 83 was at least 11 now. Okay, so almost, I would say, all people here think it's a very important to screen for colorectal cancer. I didn't talk about what kind of screening, but at least as a statement, most of people here think it's a very important to screen for colorectal cancer. Next, please. We should only screen high-risk group. Probably Dr. Umar Asba'i, you've seen who's high-risk group and who's an average risk. For example, family history, things like this. Only screen high-risk group. Totally agree, partially agree, disagree, and totally. Can you vote, please? Okay, can we have the result? Okay, so I would say 43, so majority said no, it should not be only. There is 18 to 25% think this is, might be the code. I will ask the next question, then I'll come to the panel. Next question, please. We should screen average risk group. Can you vote? Our risk group is 45 or 50. If we go by our data, might be a 45. Might be the right answer. So totally agree, partially agree, disagree. Can you vote, please? Okay, can we see the result? Okay, so 59% totally agree, 26 partially agree, and 7 to 8 they don't agree. Okay, so let me ask the panel. I'll start with our surgeon. What do you think, Nasser, about this screening to start with? Okay, whether this is a high risk or average risk group, what do you think about? You gave us your conclusion, but would like to your comment again.
I think we should not go by the risk groups if we're trying to establish a national screening program.
Yeah.
Number one. Number two, I think if we define our objective, we're looking for polyps in this general population, then I think we should start the screening program, not because of the cost. I'm not looking at the cost, but I think before we do this, we should sit and discuss, can we do it in terms of who should be doing it, the workload, the complication that could arise. For example, I'll just give you an example. If somebody had a colonoscopy, who is going to issue the next appointment for the next colonoscopy?
Next step.
Is it going to be an automated system through a software?
Yeah.
Are we going to have a hub or a server for all the data to be collected? Is this data going to be linked to the national identification system for Saudi? For example, in Japan, they're now discussing the issue of if you have your Saudi ID, then we could easily identify your age through the system in the Saudi ID, and we could, since your Saudi ID is linked to your mobile, then we could easily send you, when you fulfill the request, for example, at the age of 45 or 50, we send you a message on your mobile telling you you're eligible to have the screening. And the second issue is, based on the fact that your mobile is triangulated, so we know where you're living based on your mobile, then we could tell you go to that center for screening, which is closer to you. This is the system going on now, discussed at the level of, I guess, countries like Japan and US. And I think this is the way we should do it. Should we start it? Yes, I agree, we should start it. And it's a learning phase. I think when we start, we're not targeting 20% even of the population. We're probably targeting 10%. It will be a learning phase for us to perfect ourselves during that time, probably 5 to 10 years, where we perfect our system, where we perfect our procedures, where we perfect our surveillance methods, where we gain the experience how to deal with these patients. And that learning phase probably will help us launch this, because I believe the Saudis are heading towards higher rate of colorectal cancer. Now the increase, we said 1,000 cases, the colorectal cancer, but you have to understand there is a denominator change. the population of Saudi is increasing over the years. As a result, even if the incidence is low, there will be more cases. So it will surpass the 1,000 mark.
Dr. Garawi, you have a question, you have a comment?
What is an average?
Just a second. Do I see Dr. Alan Barkin? Can you kindly come to, do we have, yeah, can you kindly come here at the stage, please?
So let me ask you.
We have an expert here also, so thank you, Alan. Yes, Dr. Faisal, sorry for the interruption.
What's the risk? What's the average risk? Do you have this information? Is our data enough to call for an average risk? I think our data is still premature. We don't have enough data to conclude from. That's the point that I want to try to make.
From probably the literature, most of the literature saying you probably start 10 years before. So I think we have a good data now saying our age at diagnosis is probably 55, male probably 60, females 54 as mentioned. So maybe from this point, there is some scattered data about also adenoma rate, although it's in symptomatic patients, being shown probably 19 to 25% from some of the literature. That might actually, although I totally agree with you, I think we still need probably more data. What do you think, Alan?
Thank you very much for inviting me to speak. Just so people know, I'm actually the person in charge of the population-based colorectal cancer screening program in our province. In Canada, it's organized by provinces, healthcare, and each province has it now, or most of the provinces have a population-based screening program, including Quebec, which is 8 million people. And we're going through, amazingly, very much of many of the questions, concerns that you're going through right now. We're a little bit more advanced in the sense that we are actually running phase 2 testing now on a FIT-based program. From hearing all the excellent presentations, and I think they were very well targeted as to the problems, one of the issues I would have for you, obviously, is the age at which you start being concerned about it. It clearly appears to be earlier, both from the data that I saw, and you may or may not know that in the United States they are thinking of lowering the age of 50 to 45 for African Americans because they are showing different types of behaviors. Whether this is socioeconomic, biological, genetic, and so on is unclear, but it is being considered and proposed, although it has not been adopted by societies. There is one key question that I cannot answer for you, and you have to answer it with the ministry, is that I'm just thinking politically down the road. Here you are all deciding together, yes, we should look for colon cancer, but you have gastroenterologists and colorectal surgeons in the room. You actually need to look at other things and other biologies and see other programs, and I think you'll need to discuss, presumably, with the ministry at some point in time, where this fits on the overall picture versus prevention for infectious illnesses and so on. That I cannot answer for you. But I completely agree with Nasser's comment that you have an opportunity here that very few countries have had so far, and that's to be able to start developing an infrastructure for when you do hit the wall, and you will hit the wall, there's no question about it. All the countries are going this route, then you'll be set. And the key components that I would mention to you are, and I think perhaps hasn't been discussed quite as much in the context of colonoscopy, and that's quality of colonoscopy. I respectfully submit to you that if you look very carefully at the quality of the colonoscopy being performed, you'll be surprised and probably realize that it's not as good as you think it is. You're never as good as you think it is, and I can tell you it's humbling. And in Canada, we have data, and it was very humbling to see it. And you actually can use a deliverable from getting set up together to at least improve the quality of the colonoscopy on Saudi Arabian soil, which I think is a very good initial deliverable. In addition, you do need to look at, as you were suggesting, a whole infrastructure of being able to coordinate things for patient callbacks and so on and so forth, accreditation, etc. We're developing a quality program much like the UK is doing right now. And it's very difficult to do, and it's hard to get accepted. And so I commend you for the effort you're doing. The numbers I've seen, I can't answer whether it's so important that it should be a priority for the ministry, for example. You need to look at it in the context of other issues. But it is concerning that your data are worse with regards to survival compared to the US. it is concerning that you're having people developing colon cancer starting at a younger age. And I think it's, to me, and again, I'm a gastroenterologist as well, but I think it's very reasonable to say, let's try and at least aim for a subgroup of patients, at least to start with. I don't know which you can decide together, which you feel, and get this infrastructure there so that we're doing it the right way, and we can move on. And when we do hit increased numbers, as you were suggesting, we actually have a well-working infrastructure. How you do the screening and so on, obviously colonoscopy will be a key component, and even if you would do FOBT, for example, and I saw your numbers for costs, you're still going to need colonoscopy. At the end of the day, you need a good colonoscopy infrastructure, and my personal bias is that that is the key to any proper screening program. You need good quality colonoscopy being performed, and I think that in the Western world, this is where people are really focusing right now. So at the end of the day, the message is a very positive one for the association.
Very good. Very good. Okay. Yes, please.
In the early 2000s, when in the States the colorectal cancer screening started, what Dr. Sani said is very important. We are looking for polyps. We are not looking for cancers. And this is a very big issue. So when they were discussing to do the colorectal cancer screening in the state in early 2000s, Douglas Ricks, who was at that time the chairman of American Society of Gastrointestinal Endoscopy, and he's the head of ACG, a guy who is very eminent and doing colonoscopy about 25 to 30 in a week. He's saying his rate of missing a polyp, 5 millimeter, is 25%. A guy who's doing colonoscopy 30 per week. And I think Dr. Sani, what he said is very important. Are we looking for a cancer, or we are looking for screening to prevent cancer? Polyp. When I say there is no polyp, okay, you are free for 10 years. And this is a very big issue when we speak that with respect, not a colorectal surgeon, surgeons doing colonoscopies, young gastroenterologists doing endoscopies, they are very rushed, they are thinking of money, how many cases I will do, oh, there is no cancer. Bowel prep is very bad. You are speaking about family practice. It's really a very big issue here. And I think it is difficult at this stage, according to you. Dr. Sani?
I agree with all what you've said. Now, having said that, looking for polyps is not also easy. You've said an experienced colonoscopist, he missed 25% at the time, he missed polyps.
With good bowel prep.
Yes, and therefore I believe there should be certification mechanism. Not everybody is fit for this job, even the gastroenterologist. There should be a mechanism where we can measure quality, and therefore there should be a central command center. That center will look at the numbers, they crunch the numbers, they'll look at the results of the colonoscopies of each center, they'll look at the data, they'll audit the data annually with a report. And they'll look at the data, for example, of a center A and an individual A, and look at his, how many cases he missed, how many cases of colorectal cancer were diagnosed in that area, and how many of them were screened. And based on the data, objective data, you'll be able to tell if that center is doing a good job or a bad job. That's why I was talking about governance. There should be a governing body for this. Now, I'm not sure the Ministry of Health is the best person to be governing this complicated service. It's very complicated.
Okay. We have to proceed because we still have lots of questions. I'm sure there will be many interactive discussions. Can we go to the next question, please? Okay, we can screen for colorectal. Yeah, okay, so, okay, we can screen for colorectal cancer in Saudi Arabia. I mean, it's feasible to do it. So this is probably the discussion just happened. What do you think? Can you vote? We didn't talk about, by the way, colonoscopy or it's general question. Okay. Can we see the result? Okay, so here there's some divergence here. So 37 up to 28% agree, and then there is another 35% think it's not possible. Can we go to the next? We need to know the adenoma prevalence in the average risk patient in our population. Can you vote? Okay, can we see the result? Okay, so almost everybody thinks this is a very important thing. Next question, please. We should screen using fecal to occult blood testing every 2 years. Can you vote? This is our to start with, at least. Okay, next. Okay, so some people agree, 33% don't agree, and 6%. So there's some disagreement here. Okay, next. We should use fecal or FIT and colonoscopy in case it's positive. So start with FIT. If it's positive, every 2 years. If it's positive, then you can do colonoscopy. Can you vote? Okay, can we see the result? Okay, so most of people agreed about this mechanism of screening. Next question. We should use sigmoidoscopy. So no FIT, no FOPT. We should just use sigmoidoscopy. Can we vote? Okay. Can we have? All right. So 35% majority probably disagree. Next question, please. We should use colonoscopy every 10 years, which is in average risk patient. This is okay. Can you vote? Okay. Can we have the answers? Okay. So most of the people actually think colonoscopy is the right things to do. Next question. We should use virtual colonoscopy, CT colonography. Can you vote? Okay, so we have, okay, all right, so almost, okay, great. Next question. The public is aware, people are aware of the benefits of colorectal cancer screening in our area, because this is very, very important, I think, question. If you apply this, is people really aware of this or not? What do you think? Do you think our people here in Saudi Arabia are aware about colorectal cancer screening? I'm asking about the public now. Okay, this is still 2%. Can you vote, please? Okay, great. Okay, so majority here thinks people. Okay, so I think we'll come back to the panel. If anyone to please comment on the previous questions. Can I ask? What do you think, Omar?
Well, the issue about public acceptance is a big one. I know if you tell them that I have a test that can prevent cancer, they will say yes. But if you tell them there is risk of perforation, the public acceptance issue is very important. I know that a lot of people, if you tell them I have a test that may prevent colon cancer in you, they would agree to it. But in our community and society, if you tell a patient that you're perfectly healthy, I'm going to do a procedure, and I put you to sleep, you'll be sedated, there's a potential of risk of complications, 1 in 1,000, a lot of patients will say, no, I don't want that.
Okay. What do you think, Dr. Garawi? Abdullah?
I think we are still too early to decide about screening programs. Our numbers as gastroenterologists is not enough, and we should really consider other methods such as CT choreography, and we really have to make the people more aware of the problem so that we can select the cases we need to screen.
Okay. What do you think, Alan?
I think you're going to have to decide.
In general.
I think as a society, you're going to have to decide what type of screening program you want to implement. The states have done something very different. For example, then the UK, and then Canada. You're going to have to decide whether you make something available and then try and ramp up the resources, let it be colonoscopy, CT colography. I agree that you need everything on board to be able to tackle it. Or you're going to have to decide whether, in fact, you want to try and roll out a program that will offer equal opportunity to everybody. And so that you actually go to people and test them, as opposed to them come to you. Because, of course, you always have a selection bias. The people come to you or they're better educated, who have more money, etc. And you're going to have to decide how that goes. And I think that will decide, in part, what the resources are and which ones you ramp up more than others. And perhaps a good thing to do is to start with public awareness and increase the level of public awareness, see a little bit how it's going, because you may be surprised that your population may behave very differently. You know, in the States, there is no population-based screening program. It's not entirely true. There are some focal areas. But what they did is they said, colonoscopy works, let's go for it. It's a free market. Who wants it? And in Canada, we said it's very different. We said, look, we feel it's equitable. Everybody should be allowed. We are going to go and take the responsibility for initiating the process. But then you have a responsibility to make sure the resources are there. In the first case, it may not be entirely true. So I think a lot of the questions or the answers that you have here will depend on that basic fundamental premise.
Great. Okay, so we'll go probably with...
May I?
Yes, please. Yes.
Okay. Well, it's very apparent that the issue of polyp is very important, which is probably of more importance to the public than the cancer, because cancer is the late stage. You asked one important question is what's the percentage of polyps in our area? Unfortunately, none of the lecturers presented this today, but I can tell you at least in our center we do almost more than 1,500 colonoscopies a year. The rate in our hospital, talking about between 19 to 20% detection of adenomas. Okay, so it's very important issue, and we should not neglect the importance of the polyps. Definitely missing small polyps is not that significant, because 5 millimeter polyp, most of it will be hyperplastic or even small adenomas. And then if you miss it, it's not that big deal later on. Now, about the issue about the number of people capable of doing the procedure, it's always said, if you put your step toward the road and start walking, you will reach your destination later on. But if you keep sitting on your chair and say, I don't have enough staff, then you will not be able to do. It's always said also that if you open the restaurant, then you get customers. If you keep your restaurant closed, you will not get it. I'm sure once we start, propagate the awareness in the public, when we start using it, we'll have more manpower. In addition that, I'm sure, and everybody knows, that there are many gastroenterologists, they do endoscopies for very clear, very unimportant indications like dyspepsia or etc. I'm sure when they get themselves, overloaded with significant procedure like screening colonoscopy, then they will start to limit performing these procedures in the interest of devoting more time toward the screening colonoscopy.
Great. Hamad.
Hani Jawa from King Abdulaziz University. So thank you for all the speakers, and I think this was actually very informative and very useful for a gastroenterologist who's starting his practice. However, overall, I think it's, at the end, I think many people just feel very frustrated about the whole situation, because, well, number one, definitely I think that the public, the answer of your question, the public awareness is going up, and every year we see that, there are actually locally we have public campaigns. I totally agree with the way Dr. Nasser, showed us the numbers, and, the reality is, and maybe same that, like many other countries, the resources are not sufficient. However, what, is not clear for me and for many, practitioners, and I think for the public, is, okay, so we don't have resources now, so what is the way going forward? Is it, is the Ministry of Health is our, goal? Is just to have actually, a task force committee that, reevaluate this, constantly? Of course, all of you know that healthcare here is very segmented, which make things even worse. So just for us, I think it's not very clear what's the way going forward in terms of, okay, we all agree that resources maybe are inadequate now, but I think you always have to start somewhere. At least just by filtering all these number of patients to screen, or maybe just focus on the high-risk patients. Okay, thank you very much.
Thank you very much. If you allow me, Hamad, because I'm tight of time, so I'll come back to you, inshallah. We still have many questions. Still have also panel who didn't talk yet, which I think is very important to have their opinion. Okay, next, please. Patient would accept the idea of colorectal cancer screening. We asked before about the awareness. Here is the question. Do you think they would agree if you said, okay, can you totally healthy, 45, 50, and you said you're due for your colonoscopy? Can you vote? Okay, can we see the result? Okay, so there are 31, 38, so would say totally. So, okay, so at least partially to totally agree is not bad here. Okay, next, inshallah, I'll come back to you, Rashid. Next question. What the percentage of patients you think would accept the idea of colorectal cancer screening? Less than 10%, 10 to 20, 20 to 30, 30 to 40, more than 40% of the population. Can you vote? Okay, can we see the result? Okay, so maybe we will say, okay, we have very good 20. Wow, that's even, I have to say, in I think in 2009 in United States, less than 30% of the US population would agree. If they've been talk about colonoscopy screening, they would agree. So I hope we have this result, although Nasser will not like this, because if it's 10%, then that's probably agree. And that's probably another also argument about, okay, as presented by Nasser, do you think everybody would agree? Okay, 300, I think, say 300,000, if I still remember well. Do you think they would agree? Probably not. Probably you're talking about 20, 30. Yes, I agree, totally agree with that. I think we should enforce on this. I think we should have. But at the same time, those people who are, as in every disease, like coronary artery disease, a smoker, you ask him to stop and he wouldn't stop smoking. So you cannot force him to stop smoking. But at least people who are interested and who want to do the screening, who want to, very important about his health, I think it's very important. Whether it's feasible or not, I think we discuss it. But back to Professor Rashid and back to Ahmed, inshallah. Afwan Hamad, wallahi, I like your comment, but...
Thank you very much for a very puzzling problem, because we faced that several times in so many different ways. One, you're biased, and that's not the right way of doing it. When you tell me I'm a patient, you've took me outside of the concept, so please next time for our healthy person will answer differently if you wrote patients were not, so that was a bias we should really avoid. One, I think one of the things that we are not really good at is speaking to the public. We speak to ourselves, and we are very poor in listening to the people. Second thing, I'll give you a question, I need raise of hands. How many people above the age of 45 had a colonoscopy? No, just look at it.
They're all embarrassed here.
No, I'm just pointing out, we are the people that 70, 80, I want a healthy, not for a specific, but for a screening concept.
I'm healthy, no,
yeah. And I'm just pointing out that we are the leaders, we do not believe in it. Generally speaking, we're not speaking about specifics. So, what we need first from you guys, the experts, we need guidelines of what to do with the 20% polyps that we can follow and then aggregate our data and see. Second is, we can never do the numbers, but we could do a high risk then we go to a lower, go downwards until we reach that. Second is, all modalities should be used and nothing one. And I think one of the things that we have to understand is this is an area where failure is much more anticipated than success in our community because of the concept of colonoscopy in a general population. So we will have to figure a lot of other modalities, even if it's more expensive or less expensive, if we're thinking of reaching it and getting that. Thank you.
Okay, I cannot keep you standing, Wallahi Hamad. Yes, short, please.
طبعا, I will say what is sad here, we're still seeing 7% this small bars, and in spite of excellent lectures, so we are hearing about colon cancer screening, the audience here are not convinced. There are still al-khatt al-yasari, al-mu'arid, always.
That's very normal. That's normal. It's
normal.
It's
this is part of life. This is part of life. I think what Dr. Iyad said, I will stress. First of thing, we convince ourselves, are we, as a gastroenterologist, doing this to all our patients? We should be convinced, the people who are doing it, to start. And at least, as Dr. Iyad said, we should start. And we start for the very high risk, and then we'll continue, and we'll reach, inshallah.
Thank you very much. I need Ahmed. What do you think, Ahmed? Yes, please.
Okay, I think most of us, we do agree about the principle of screening. So all what I think we have some disagreement about is how to do it and who should have it. Okay, and these, I mean, if we agree about the concept, I mean, we can have further discussions about how and who. The other thing with regard to the people, whether they will accept, I mean, that concept or not. From my own practice as an oncologist treating colorectal cancer patients, I usually find it a little bit easier than, for example, my colleagues in public healthcare, like a public system or something like that, because my patients' relatives, they have a concrete example in front of them. And sometimes when I say, if you do like this kind of screening program, you would prevent this kind of catastrophe. So, I mean, with regard to the acceptance, I agree. If you're talking about the general population, it might be a little bit difficult for, like, social, cultural, and maybe some, I would say, educational kind of problems. Okay, so we need to do more education about the importance of having screening programs. We have to have, like, more access to the general public, I mean, to talk about the screening issues.
Thank you. We'll go with questions because I think there are still very important questions that might answer some of the questions raised by Dr. Nasser. Next, please. Physician would accept and be involved with colorectal cancer screening. So we discussed that before, but would like to know your official vote. Okay, can we have the result? Okay, so most, at least, things, at least our gastroenterologists would agree. Next. Endoscopist would accept and perform screening colonoscopy. If you say colonoscopy is you think endoscopy, knowing that waiting list in most of our endoscopy units from 4 to 6 months. So you think people would like to do more. What's that? We will come to that. We'll come to that. What's happened in general? Okay, can you vote? Okay. Show me the result, please. Okay, so we have a very nice, energetic endoscopist. Next question, please. Okay, I think that's one of the very important questions here, especially Dr. Nasser, about if we're talking about the insurance company. We know insurance company here, they don't cover screening. So if it's happened and that we say, well, this is a very important, has to be done, and insurance company, for example, agreed about this, then I think the equation would be totally different. If the endoscopist is doing 6 colonoscopy per week, he will do 60. I can assure you, Nasser. So And that will be, I think, will be totally, if you're having 3 doing 60, then that will be totally different. I think that's a very, so first of all, do you think if we say, okay, this is the guidelines, this is the statement, this is, Dr. Nasser is the head of the colorectal, this is the Saudi Gastro Association, and that's what they recommending, and do you think insurance would accept this? Okay, can we see the result? Okay, so most people don't believe in our insurance companies. Okay, that's a very important thing. Next question. So many patients would not have an access to screening. So, okay, you say that. Do you think many people will have, or you think this statement is right? Many patients would not have an access to colonoscopy, who's at average risk and who is due for colonoscopy. Which is another question raised by Nasser. Can you vote here? Okay, can we see the result? Okay, so many people say this is probably the case, and many people will not be. Okay, my last question. Ministry of Health would be happy to cover the cost, or at least be heavily involved with colorectal cancer screening program. Knowing that already they've been involved with treating metastatic lesion, they are spending a lot of money. Do you think they will be happy to do this or not? Please. You are دفع لك الوزير شيء يا حماد ولا؟ Can you vote please?
نتكلم داود الشريان يا عبد الرحمن.
Okay, can we see the last one? Okay, so most of the people thinks they might not. Okay, now I think this is, we have to conclude with this, and probably 5 minutes discussion. We'll go with Sana, please. We didn't hear, yes, Muhammad.
There is one issue. Now, the diagnosed cases, already diagnosed cases, they have to wait for treatment relatively long, for surgery and for treatment. So our resources are not covering what we are diagnosing now. So we should really consider to improve not only the screening, but also what is after the screening, that it is still now not available.
That's true. So what will happen, your question, what will happen after you discover, for example, things? Would you have a very nice referral that you send them or not? Okay, to start with, you might have difficulties, but later on, do you think that will increase the prevalence? Nasser, do you think that will increase the prevalence of colorectal cancer, means will increase your load as a colorectal surgeon?
It will definitely increase the load. And today, as we speak, the number of colorectal surgeons in the country is 20, while we need 50. And most of them are located in the major cities, while we need them in the peripheral cities. And that's why we have a board to train people in the peripherals so they can start colorectal surgery there. However, having said that, I still think, in spite of all these problems and difficulties, we should start and lay down the system, and there is a learning phase of 10 years before we can get it straight.
Sure. Sana, I'm sorry, we need...
It was thoroughly discussed, but the only issue I will add that really we need to start our screening program, because even I'm from military hospital and we are seeing a lot of patients, young ages, and even last week we had a patient who's 30 years old, was completely healthy, and she developed this cancer stage. So I think we should have the infrastructure and start putting a program for it and see the best way of doing it, and then we take it step by step, and I think it's a very important issue to do.
Nawaf?
Just an asking question. Do we have any data about the incidence of polyp in our colonoscopy, our patients? Because I guess if we have this data, I have done a paper in Australia about the incidence of colonic polyps in around 1,000 patients over 3 years in Adelaide Hospital. And we have found this number is almost 20 to 25%. They do have adenomatous polyp. And there we have a recommendation. They have, according to Dr. Nasser, they have infrastructure which they do have. They call the patient about the due date. So after 5 years, they do have the date for this type of patient to come, and the family physician, they're going to do the bowel preparation, so they will come immediately to the endoscopy unit to do the endoscopy. And in fact, we are in that group, that study, we're just looking for the patient who they do have quality of screening for group who they have above 80 or 75 years old. Who they do have lots of comorbidities. Still we have a screening program for this group of patients, and that's the question which we raised from that data.
Okay. So probably, if we're talking about the prevalence, I don't think we have a prevalence among screening colonoscopy. I know there is some studies among symptomatic patients, like the last 2,000 patients in my unit, at least in our unit. I think, Dr. Iyad, is this screening what you talk about? And that's, by the way, it's 19% in our unit. That's what you're talking about, Iyad? Is it a screen? Yeah, it's symptomatic patients above 40 or above 30.
Yeah, it's the data on symptomatic patients,
Okay.
not screening
Yeah,
purpose.
yeah. So I'm not aware of anything.
So maybe
I'll come back to
higher
you.
even if it's screening.
Yes, Nasser. Thank you, Iyad. Yes, Nasser. معلش أشرف.
CAST already last year gave a grant for someone to answer this question.
Okay.
Incidence of polyps in
Very
patients
nice.
with colonoscopy.
Excellent. Yes, Alan?
My only caution would be is if you don't have good quality colonoscopy, your data will be an underestimation of what it is.
That's absolutely
We know
right.
this. Someone mentioned before the 15% pickup rate of adenomas in 2002 with missed polyps by Doug Rex. Absolutely.
Yeah.
Today we know that 30 to 40% of males and females have adenomatous polyps because we're finding a lot more serrated adenomas, flat adenomas. We're looking for them. So you need to be careful about those data, and you need to ramp up the quality as well to have credible information.
I think that's a very valid female, please. We don't hear anything.
Assalamu alaikum. Jawahar Al-Mali, nurse endoscopy in King Khalid Hospital. My question is for you, Dr. Abdulrahman, for Dr. Faisal Batwa, for Dr. Nasser, for all the endoscopists. After all this discussion about the screening and the colon cancer, don't you think that it's time to think about nurse endoscopists in Saudi Arabia for screening?
I think it's a very important question. So you are interested to do screening, if that's the question, or sigmoidoscopy or colonoscopy? No, I don't think anybody does, but sigmoidoscopy, it's practiced at least that I know in UK. Yes, yes, okay, very good. I think we'll back to your question, but since people are just Hani Ashraf.
Yes, I just want to share with the committee my experience when I was a consultant gastroenterologist in the UK. I've been consultant in the UK for 3 years, but they were in the same stage as you are now. They've been fighting to convince the government to start screening colonoscopy for many years before it started. I think it started in 2008. And it was always discussion about this for many years before they convinced the government. And how they convinced the government, I mean, as you know, the UK, they always have problems in the economics and the money issues, the same problems as here. And I was really impressed with Dr. Al-Sana data and costing issues. And the start point in the UK, they convinced the government by showing that by doing screening colonoscopies, it will save after some years, I can't remember the data exactly, but it will save the referrals to the oncologists, the emergency admissions to A&E, and the time lost in the jobs. And the problem here, we don't have all these data for the use of oncology and the palliative care. And also the other point, about Dr. Al-Sana presentation. I think why some people they present late at late stage here. I think we don't have primary care, family physicians. In the UK, if any patient presents with PR bleeding, he would be referred straight away to colonoscopy and gastroenterology.
Thank you. That's a very valuable. I'm sorry that I have to limit one, and because I need a final statement from some of the panel. No, Hani, I have no idea. Yes, please.
I am Abdul Jabbar Al-Fattani. I am family medicine doctor.
I'm very happy to have you. Yes.
Okay. I have good news. We are in the Ministry of Health. We are establishing a screening program, and one of them is colorectal cancer screening. The problem is we have multiple lack of awareness from people and doctors. I have a study done of that. We are lacking of information about importance of screening, even in people, normal people, and even in doctors. So in Ministry of Health we are establishing, and I hope it will be, at least we will start this program maybe at the end of this year or maybe at the beginning of the next year.
Thank you for that. Yes.
Thank you, Dr. Azbedi in King Khalid Sultan Najran. I think it's difficult to start screening in the whole kingdom, but there is a regional area of high prevalence. And high prevalence, like in our Iran, 80% of cases is below 40 of age with colorectal cancer. If we start program in specific regional area with high prevalence as the first step, it will be very nice.
Thank you. Because I think, thank you very much for people, but I have to, Nasser, the final comment, and unfortunately we have to conclude here.
Thank you. Thank you, all the speakers. I think you raised a valid point and very nice recommendation regarding the screening for the colon cancer. My suggestion for you as SGA leader to write all this recommendation and raise it to the MOH. I think it is very important points, and we are as gastroenterologists, and we are in this meeting responsible for raising this recommendation. So please, if you can collect all the recommendations from our colleague and raise it officially to the MOH.
Thank you very much. I think having surgeons, gastroenterologists, and family physician, I think it's very, very important to sit down together, and in fact will be very important. The last thing, just before I conclude, tonight there will be a U-turn, there will be a public awareness about colon diseases, including colorectal cancer. There is a stand-up committee. I hope this is the start of awareness, and thank you very much. I have to conclude it.